Good morning, everybody, and there's a huge introduction, but this is all a load that you carry while ascending into the ladder system.
But I try to excite you or incite you with the topic of what this fusion imaging is and what is its main role in neurosciences, because as I told you that I am very interested in neuroradiology. But as a whole, it's not limited only to neurosciences, it can go into any field of radiology. What is a fusion imaging? Basically, this is also called as a hybrid imaging, or you can call it multimodal imaging. Indirectly, it means that you are combining multiple modalities, independent imaging modality, and trying to combine these two. And basically the common type of this fusion imaging is, as you know, is PET-CT, positive integration tomography with CT. What are this fusion imaging you can do? You can do a mental fusion, like as you do in 80s when you used to learn radiology and you didn't have that sophisticated say software or the computers even. You have just some plain X-rays. And sometimes looking at the skull in two views and you saw some pathology and you try to mentally fuse this apial lateral and to imagine in space that probably in brain this is the area where the patient will be. So this is what a mental fusion is. But you don't need that exercise now. You have a software. You have two images. You can fuse to these two by the software coupling, and you can show this in space where that patient is. But then one structure is moving in the body, like your heart is moving, or you are taking respiration. So when the structure is moving, you cannot do this, because at one phase you are taking one image, and another phase you are taking another image. So you try to do a software fusion, the image will be misregistered. So in that case, what you do, we use some kind of positioning devices, and the computer will detect that positioning devices in that particular phase. So you can couple multiple images with the software. But of course, you understand the best kind of fusion method is a hardware fusion. If there is a hardware, the same hardware which is used for say an ultrasound and a MR, or say a CT with a PET, that will be the classic example of a fusion. Why do you need to do a multimodal? You have a CTA placed in one corner, you have an MR placed in one corner, ultrasound, you have plain X-ray, you don't need it. Basically, your images are coming, you read those images and get the information. But you need it because not a single imaging modality will give all the information that a clinician wants to have. Indirectly, you mean that whenever you need a complete information, a single modality cannot give you the answer. So you need to do something more than what is you are getting. Then second is, when you are getting information from say a modality, from another modality, they are always a complementary. An example, an ultrasound gives you a picture with some information, and a CT gives a little better because soft tissue resolution is more. So they are complementary to each other. And the patient has normally you go to a doctor, they will write, get an ultrasound, get a CT, and get a PET, something like that. So all these three have a different connotation, and try to assemble those data sets to form an information which will be complementary to each other. Now these images you can acquire simultaneously, or you can acquire at different time set, and you can fuse this. That indirectly means if today you acquire an image and a year later you acquire an image and try to fuse those two, you can do that kind of fusion. That is required to have a diagnostic or streamlining of the diagnostic problem. Like an example, you want to study anatomy you do a CT and MR, maybe an ultrasound. But you want to study the physiology of a particular tissue, you need to go to PET or say SPECT and things like that. So in a given situation, if you want to couple these two, an anatomic information which you are getting from CT and MR versus a physiological information that you are getting from say PET CT, couple these two, and a single image when it fused, it gives you two information. It is giving an anatomical information where the abnormality are located, as well as how this is behaving, whether this tissue is a vascular tissue, is a malignant tissue, is a cancerous tissue. You can interrupt me at any point because some of the terms I might be using is medical terminology. May not understand. Either you note it down, or you can stop me and ask me that particular query. So one is the coupling of two particular information into a single frame, or you can enhance whatever information is coming from a single modality. Like a PET CT is giving an information, but that information is not sufficient to give a diagnosis. So we try to enhance that information. That indirectly means what? It's all signals, nothing else. It's a signals and noise. At the end of the image, it's what is the signal that is coming and what is the noise you have suppressed. So what we are trying to do here, you are suppressing the noise, trying to enhance or increase the signal of a particular modality by fusing. Next. PET and CT is a dual modality. We are talking about multi-modality. That means you can couple much more data set at the same. You need to have this because sometimes what happens, you do a PET study in a single scanner and you need a CT and a different scanner. Maybe two different institutions. You can couple this and can have information. When the structure is not good, then it's possible. You acquire data today from, say, at PGI and you did a CT, and you take a PET CT somewhere else in, say, Amritsar tomorrow, and you send these two images and try to fuse it. It is possible when the structure is not good. Like brain, it's not a fixed structure. It's a bone. It's a fixed structure. When you are talking of thorax or an abdomen, where there is a respiratory movement, you cannot do it. So two sets of data can be fused when there is no movement, but two sets of data cannot be fused when there is no movement. This you have to understand. Next. I think I can, the justification here is in a dual modality imaging that if suppose you are doing a PET study today and you simultaneously acquire the CT, you don't have to move the patient from one scanner to another. So you save time. The patient can be very sick and shifting or maybe such incapacity shifting from one imaging modality to another will be something difficult. So you can have a couple of informations, both the information together in one scanner. Second is when you are generating such a data set or such an image space, you can automatically align those two images, the PET and the CT or the CT and MR or maybe anything else. You can avoid complex mathematical co-registration. This is an important step of fusion imaging, the registration. That means you acquired a data set, an image set, and you acquired another set of images. You have to register in fusing so that coordinate, point-to-point registration. So when it is generating from a single dual modality, then you don't have to do that mathematical calculations. Your automatically aligned images will come, and naturally the complex mathematical part that is required for registration also. Of course, you can have an improved visualization and exact visualization. Then you can do a PET SPECT with an MR also. We have done so far PET with CT, but PET SPECT can be coupled with an MR also. What will be the advantage? Like if we take a PET study, it's a picomolar level of resolution, sensitivity, and has a disadvantage, that is 1 cubic millimeter of resolution. But when you talk about MR, it's a very high resolution, it's a similar. It's something like 100 micron resolution. You have an excellent soft tissue, which is not possible in any other modality other than MR. Of course, you have in MR no more radiation, no more radiologist and things like that. And you have a sensitivity which is much lower than what you have in PET. So if you try to couple this as a simple thing, you have an excellent sensitivity, which is some millimeter resolution. And of course, as you know, the PET and SPECT gives functional and physiological information. Similarly, MR can also give a functional information. A functional MR or spectroscopy of MR can give it a functional or physiological level or chemical level information, which a PET, you can supplement the PET data with a functional imaging data. So this is a very strong, very strong modality in terms of fusion, both as resolution as well as sensitivity. Next. Now what are the benefits? So far what we analyzed is that it provides structural and functional information in the same image. It improves the reading efficiency. As a radiologist, the confidence of diagnosis will be improved. Quantification of variations or difference can be done. You can plan radiotherapy. You can also quantify the radiotherapy response. You can have a longitudinal fusion or fusion of multiple data sets, and of course, you can do a pharmaceutical drug trial. You can do this kind of a fusion. Next. This is just a pictorial. This is what a typical PET-CT scanner. So in the same scanner, you have the one workstation for PET and one other workstation for CT, and you have a fusion workstation where you can do both the data together and fuse images and can detect abnormality. Next. And this is what the current, they have a 64 slice CT, and some of them only is a 3D rotational thing. So it depends on what kind of information you need and what kind of scanner you are going to use. Next. There are certain mixed terminology that is used. Anything that comes, fusion imaging, fusion sensors and multiple things like that. But then terminology has to be very defined. A multi-modality imaging means when you are using 2 or more imaging modality to image a patient. This is simple. Image fusion or sensor fusion is totally different than fusion imaging. Image fusion is when you are synthesizing two signals into a single one, and you are presenting that synthesized data or synthesized signal. This is image fusion. This has nothing to do with fusion imaging. And of course, the most important part of fusion imaging is the registration. Next. What a registration means is the prerequisite. If you want to do a fusion imaging, you must have that registration. By registration means when you have one data set versus another data set, one will recognize the other by some commonly identified thing. Like if there is a name, by name you are analyzing the two data sets. This is what called registration. So given an example, a particular patient has gone for multiple imaging, gone for ultrasound, went to CT, went to MR, went had a PET of the brain cells. Now registration means that either you have a computer, a software, which automatically understand the coordinates of all the images, point to point or coordinates of all the images. This is what we call the registration. Next. That's what we define is one-to-one mapping between coordinates in one space, such that the point in two spaces which correspond to the same anatomical point.
Suppose even if we have imaging from one particular kind, and for the patient we have the imaging at point P0, P1, P2, that's registration also help us to changes that occurred.
I'll be back to that particular point. What registration should do? Yes, it should be able to. If your software is so strong that even if you correct the, say you are putting a patient in a scanner in a different height. Okay, you are putting a same patient in a different height. So even your couch positions will be rectified. That's what the correct registration. So your image, in the image, finally, if you do what is the most important is the registration. If the registration is correct, your fusion is just done. So for that registration, point to point, coordinate to coordinate matching is required. I'll come back to you next. So this is how the coordinate to coordinate axis has been manipulated. Next. Now the two problems of registration: a registered image, one image to other image, and image to a real world, what the space is. Next. Now these are the examples of data sets that will be registered in a 3D imaging like CT, MR, ultrasound on a functional map, in a 2D to a functional map, in multiple projection like a DSA, where there are biplane and multiple projections you are taking, then other tissue like tissue sections to say stent sections, like that in pathology. Next. Now this is what should an image registration account for? Difference in scan geometry. It should correct the slice position, it should correct the orientation, it should correct the magnification, it should correct the thickness. So it's one of the very, has to be a very strong software, otherwise your fusion will be. So it will correct all these things in different modality. CT, MR or yeah. It also correct the variation in patient pose. If there is a couch profile deformity, it will set up errors, that will also be correct. If there is a patient movement, motion also that should correct. And of course, if there is a deformation in the anatomy, like there is a tissue which is deformed in imaging because of some artifacts or something, it should correct that also. And lastly, of course, if you want to try to register a 3D data set versus a 3D data set, it will be really a big problem. So it is possible in a 2D data set easily, but in a 3D data set it will be a huge problem for registering the two modalities. Next. So this is a sort of an example of a multi-modality interactive overlay, color overlay, so that the fusion can be done. This is one of the slides from older Peaker systems. Next. You can do a point-to-point registration. This is a software which comes with the Philips system, where from one point to another point, you can register from CT to MR, and you can exactly delineate or co-register the things. Next. You can do even from MR to plane extreme. This is a classic software which is available with the system itself, when there is a fusion imaging possible. But basically, it generates from the basic tool of, say, signal processing and things like that. That tool is now for us, we understand, okay, you could register the thing and you can find the account table. Next. This is, say, an example where you need to precisely delineate the, say, my hand movement. I want to delineate exactly on my brain mapping. So you do a PET, you do an MR, try to fuse it. This is a PET study where hand movement is been delineated and onto an MR, so that when the surgery is done, if there is any pathology in and around, it will avoid that particular area. So that images are collected, and during surgery we are avoiding that particular area to have the maximum benefit to the patient. Next. This color more, you can put any sort of color, add any color to the particular area. Next. This is an interesting one. If, say, in a tissue, you have a holologous anatomy. have a tissue which is fat, you have a tissue which is bone, and you have a tissue which is brain. So they have very different signal both in CT and MR. So that signals you can also fuse what is known as is voxel intensity based benefits. You can fuse based on that multi-voxels fusion. Next. This, of course, you can derive from a common data set, from a data set where you have only, or image data set where you have only, say, SAG images or sagittal section of the brain, and from there you can reconstruct and 3D facial reconstruction. That's what the people is here. Is actual 3D reconstruction from a broken, say, face in a blast, bone blast or something. You can reconstruct that image, add soft tissue, and then have a derived 3D image of the face or next. Exactly, you can have face. Yeah, next. This is what is an MR study, and this is a PET study. You can fuse it. You can delineate the abnormality, or you can pick up the word from the abnormal sequence. Next. Next. Now, of course, whenever we talk about this is a part which is of medical part. So far, we talked about what the theme is in the community, but actual benefits we will look into how it helps the clinician. This area may be a little difficult, but I'm very confident that you will understand what I tried to explain. Next. Now, there are some normal areas of human body which will pick up, say, signals, whether you put onto your PET scanner or you put onto a CT scanner. We know that these are the structures which normally pick up contrast, or you can call it an optic. In a PET, you call it an optic of radiopharmacy. Next. Pathological optic, we know this is what should not be there and is there. That's what called in pathological optic. A diagnosis comes from a normal knowledge of the normal anatomy and physiology, and an abnormal variation, and finally what we understand from our experiences what is pathology. What should not be there is there. Next. See an example. Here a PET data set is there, and this is a CT data set. Now, these black areas are, say, optic of radiopharmaceutical. So you have optic in 3 different zones. But on CT, what we found that these are the muscle, normal muscle, that neck muscle that comes. And neck muscle can take up radiopharmacy. So when we fuse these two, because okay, all 3 are muscles only. They are not an abnormal optic. But if you actually go back to the state, if you isolically try to read in one corner, say PET is situated, say, next building, College of Law, and there is a diagnostician who is sitting there and trying to read his images. They say it's all abnormal. Go and have surgery. When somebody is sitting here, you say, oh, these are all muscle. Looks like muscle. Maybe there's something. But when somebody is sitting in an intelligent workstation, next, he understands these are all normal. So a patient who had a known cancer or cancer tissue somewhere, whenever there is an abnormal uptake, the fear is there any recurrence or the disease has come back. So from this fusion imaging, it's very clear. Next, just that is a normal muscular enhancement that is. So it is from one end giving a pathetic diagnosis to a patient, comes to a normal where there is a very hopeful kind of thing. So fusion imaging, this is what the fusion imaging can deliver. Next. Also probably not all examples here, but this will. Here is an example of similar looking thing which we saw in the last image. take a picture of that. We know this is there's a vocal box, a voice box. So normally you will see them. But these are the has cancer of the tongue, which is already undertake surgery. This is a normal. But when you look in the CT, you don't find much. Next. We do fusion. Now these are the strap muscles or the muscle of the neck. But this is an abnormal. There is no muscle like that, and it's only on one side. So this is an abnormal. So from pate, where there is a doubt about a bigger area, from CT there is none, to a limited area where there is an abnormal. So this is what the fusion imaging is going to give us. I think I'll end this talk with the last few slides. Just a proceed. Okay. Here is say another set of things, PET CT. Here we are doing an angiogram, that means studying of the blood vessels, and we are trying to correlate with an MR or fusing this on an MR to find out whether that particular abnormality is in space in relation to MR where it is. So you can do fusion of this kind of an angiogram fusion also for stereotactic surgery. Next. And you can, of course, now what is the navigation? You are navigating as if you are doing virtual surgery. That means you open the brain and you don't know, you don't see the lesion. You have already acquired the data set and you can't see the lesion. And you know your XYZ axis, you know the depth, you know where exactly it should go. So these are the stereotactic frame. So exactly where the lesion or the abnormality is, it will be automatically directed at that particular point. This is what navigation software is. And this is one of the most important software for finding a very, very small lesion, which normally in naked eye you will not be able to judge. Next. So what is a new horizon? And many things to be yet to be done. One is that there should be a realistic biomedical model-based registration system. It's not that you start fusing on a software or fusion in a hardware. The learning should come from a biomedical model-based registration system, which will automatically identify the feature of matching, which will improve the validation and accuracy of registration. And of course, in case where there is a failure, it should give us an algorithm to find out where the failure is and to rectify that. You have to micro to macro scale fusion, and of course, you need many more hybrid scanners. Hybrid scanners means in a one modality you are. Right now, you have a PET CT. Probably you need a single model, like where you can do ultrasound, you can do PET, you can do NMR, you can do an ultrasound and everything. Next. So in conclusion, the data fusion allows the matching between different complementary information. Methods highly dependent on the clinical application. Few products are clinical multimodality application except in stereotactic. Anatomic function fusion, image guided surgery. Thank you very much.